Hi, my name is Dr. Liz Angelewski, and I'm the Director of Clinical Education and Training at Theralase. In this clinical education video, we will discuss patellofemoral pain syndrome, a frequently encountered condition that involves the patellofemoral region of the knee and often presents as anterior knee pain involving the patella and retinaculum. Patellofemoral pain syndrome is the most common cause of knee pain and is usually the result of overuse. It describes a symptom complex and is usually a diagnosis of exclusion. Patellofemoral pain syndrome is among the most common diagnoses in sports medicine. It is often seen in active individuals, especially runners, and may account for 25 to 40% of all knee problems seen in a sports injury clinic. The condition typically affects more women than men and is prevalent in active adolescents and young adults, particularly under the age of 45. Patellofemoral pain syndrome appears to be multifactorial, resulting from a complex interaction among anatomical and training factors. Overuse, malalignment or improper patellar tracking, and trauma are some of the common causes. Of these, overuse or training overload is the most common. The majority of patients with patellofemoral pain syndrome participate in activities that overload the knee's extensor mechanism or patellofemoral joint, leading to injuries such as subchondral bone degeneration, retinacular strain, and damage to small nerves, which culminate in the syndrome. Another potential cause of patellofemoral pain syndrome is abnormal patellar tracking, where knee pain arises from abnormal force generation and distribution during movement of the patella within the femoral trochlea. The onset of anterior knee pain may be gradual or acute and may be precipitated by trauma. Pain may occur in one or both knees. Typically, the pain is aggravated by squatting, running, particularly downhill, prolonged sitting, or when going up or down stairs. Pain is localized under or around the patella and is usually described as dull or achy. It's important to ask the patient about exercise history to identify changes in their training load. It's also important to ask about any prior knee surgeries or knee injuries, especially to the patella. To confirm the diagnosis, an examination of the knee, focusing on the patella and surrounding structures, is essential. Upon observation, look for obesity, vastus medialis atrophy, angular and rotational deformities of the lower extremity, and swelling in the area. Determine if the quadriceps or patellar tendons are tender upon palpation. Pain with resisted quadriceps contraction and pain with squatting may be diagnosis of patellofemoral pain syndrome. A weak vastus medialis oblique, VMO, and gluteus medius, hip abductor, are common. For many patients with the clinical diagnosis of patellofemoral pain syndrome, imaging studies are unnecessary for initial management. Radiography is recommended in patients with a history of trauma or surgery, knee effusion, knee instability, or pain at rest. Otherwise, imaging is not performed until the patient's symptoms fail to improve with appropriate conservative therapy. The goals of treatment for patellofemoral pain syndrome are to reduce pain, improve patellofemoral tracking and alignment, and return the patient to a high level of function as quickly as possible. The acute phase of treatment focuses on pain control, which is week 1. The subsequent recovery phase focuses on modification of risk factors and biomechanical deficits. In the acute phase, patients will need to modify their activities and avoid those that cause pain during rehabilitation. Most runners will need to reduce their running volume, and those with severe signs or symptoms should cease running activities altogether. Applying ice to the anterior knee may help relieve pain and reduce inflammation, and there is no empiric evidence to support the use of ultrasound or electrical stimulation in the treatment of patellofemoral pain syndrome. In the recovery phase, the majority of patients experience a resolution of symptoms following conservative treatment. About 40% of patients diagnosed with this syndrome continue to have symptoms up to 1 year following typical conservative care. Evidence does suggest that exercises to increase strength and mobility improve symptoms and function. A comprehensive treatment approach should address hip abductors, iliotibial band, quadricep muscles, the hamstrings, feet for excessive or insufficient pronation, as well as core musculature. Stretching of the quads, hamstrings, and IT band, and strengthening of the hip abductors, quads, and core muscles is important. Adjunctive therapy may include orthotics to help control excessive foot overpronation or supination, and patellofemoral taping or bracing to help participation in rehab exercises. The Theralase TCL-2000 therapeutic laser is well indicated and very effective in treating anterior knee pain in patients diagnosed with patellofemoral pain syndrome. In a majority of cases, the pain is reduced after the first few treatments, with subsequent healing of affected tissues greatly accelerated. It is recommended to have the patient seated with the affected leg on a low stool or set of books, approximately 8 inches from the floor, and the knee in approximately 30 degrees of flexion. Treat first above the knee joint in the area of the distal quadriceps tendon, located just above the patella, then medial and lateral to that location, followed by treatment of any tender or painful areas. Treat the patient every day for the first 3 days, then 3 times a week thereafter. Treatment protocols are customized by the Theralase TCL-2000 automatically based on patients' physical characteristics. Pain will continue to decrease, mobility will continue to increase with each subsequent treatment. For acute pain, an average of 5 to 10 treatments is recommended, and for chronic pain, an average of 20 to 30 treatments is recommended.